thank you for coming and enjoying your lunch with me. I want to start off by certainly telling you a little bit about what we're going to talk about today. But just out of curiosity, so I have an idea of who's in the audience. How many of you are medical doctors? Just by a show of hands. How many of you are PhDs or PsyDs? How many of you are master's level? Okay. And how many of you are on the administrative side? So okay, perfect. And how many of you don't fit into that, any of those categories?
Hpa Axis.
Perfect. Okay, perfect. All right, well, I want to start off by telling you a little bit about my history academically, and then we'll jump right into the presentation and what we're going to talk about. But before I do that, is there anybody that came to this presentation saying, I hope Joe answers this question? Is there anybody who's just dying? That way, as I talk through the presentation, I'll try to answer the questions, and then hopefully towards the end of our time together, we will actually make sure that you can ask those questions if I didn't answer it. So one, what was the question?
So my question is, for those of us who are not in recovery, how can we utilize NAD for rejuvenation and integrative healing properties?
Okay. So just to repeat, the question was, how does NAD apply, or how can we use NAD if outside the addiction world? And I will touch on that in the presentation, and then hopefully we'll have some time at the end of the presentation to talk more to that. Other questions? Yes.
What are the top two factors that would keep insurance companies from recognizing this as a viable treatment for detox?
Okay. The question was, what are the top two reasons maybe why insurance, I'm going to say that in a different way, is not reimbursing NAD? And we'll talk about the reimbursement models with NAD and insurance. I don't go through that specifically in the presentation. We'll probably address that towards the end of the presentation. I'll try to give you some insight into how that world and system works. Other questions?
I don't want to know what's in the IV that you give everything.
Okay. Just a little bit of that, a little bit of that. So yes, I will go through, and maybe if we have time, what I'll do is I'll show you what's actually not in this presentation, but how we actually have a protocol that says this is what's in each IV. And of course, it's different for the patient that comes in with benzos versus the patient that comes in with addiction X versus the patient that has liver, kidney, fibromyalgia, blah, blah, blah. So we are all in healthcare. We know how specialized healthcare is, but I will give you some general guidelines. Other questions that we want to make sure that we address as we go through. Okay, just out of curiosity, how many of you, with a show of hands, have no clue who I am or what I do at Sovereign? You may have seen an email from me. My title at Sovereign is Director of Strategic Operations for the entire organization. I also oversee many of our ancillary programs. So I wear a minor clinical hat, but I wear primarily an administrative hat. And so I'll tell you a little bit about my academic career, because I think it sheds some insight into why NAD and why me for NAD and some of these ancillary services. So when I started my academic career, I was going into neurology and was accepted into medicine, and I decided that I wanted to be a neurosurgeon. I then went on to get my master's in clinical psychology while I deferred in medicine. After deferring, got introduced to a field called psychoneuroimmunology. Anybody in this room know what that word means? It's very relevant to understanding integrative medicine, and it's very relevant to the mind-body connection. And essentially what that means is, what's the connection between the mind and the body? Understanding that dichotomy between physiology and psychology, which is extremely important when it comes to neurology, extremely important when it comes to NAD specifically. And so I deferred on medicine, did my master's program, went on to get licensed, specialized in health psychology, did a postdoc in neuropsychology, went back, and now I'm a fellow in lifestyle medicine, and just for fun decided that I should have an MBA as well. So I like to read is what I tell people. I tell people I have a diverse education, but I have learned how to read really well. With that said, I will talk a little bit about how those disciplines all come together with NAD, and we'll go from there. But a little bit about what we're going to talk about today is, hopefully everybody is here because they want to have a better understanding of what NAD is. You want to understand how NAD actually works. And I think in order to define how NAD works, we need to understand the mechanism. When I say mechanism, some of this is going to go into, sorry, I'm standing in front of it, the neurobiology as well as the pathophysiology. So then we, of course, want to talk about the patients or the clients that you see, how NAD can apply to them, and of course we want to talk about my baby, which is, what's the take-home message? I want everybody in this room to leave this presentation with 2 or 3 sentences that they can say to the person sitting next to you about what is NAD. That is my purpose in presenting to you today. So you're going to see some repetition, and I'll be a little bit obnoxious about that. Just a little bit, probably a lot. We'll go through, of course, the history of NAD, and talk more to who's a good candidate for NAD. Any questions so far? That's the hard part. Now that you have the agenda, is there anything on that agenda, and did that stimulate any additional questions that anybody has? Yes.
How NAD can be associated with ED, like in treating an ED.
Okay. So eating disorders specifically?
Yeah, and how it can,
Okay. We hopefully will talk about how NAD fits in with eating disorders, some of our neuropsych background, some of our specialty programs, and some of the other programs that we have. But specific to Sovereign, I think we need to go back to our DSM days, and those of you studying your licensing. And you can't talk about NAD without defining what addiction is, right? So let's make it simple. There's 3 words put there in red. Can anybody tell me why they are in red? What are we talking about when we talk about addiction? Anybody? Everybody in here is right. Dependence versus tolerance. It's in red.
More.
You need more of something to give you the same effect, right? And what we're really talking about when we deal with addiction is withdrawal symptoms, right? Is somebody bold enough to tell me that they have a patient that they have worked with in the world of addiction that does not deal with withdrawal? Okay. Can somebody tell me that they have a patient that doesn't have a harmful effect as a result of this addiction? Can somebody tell me that their personal health does not have a harmful effect? Okay, so this kind of means NAD is pretty applicable to every single person in this room. So let's start with NAD. history. Because if you're like me, the history is not the exciting part. But it's something that we need to know to respect. And when you go on the internet, and how many of you Googled what NAD was before you came in here? I think what you're going to find is most of the literature will tell you it started in the 60s. And it started in the 60s with a couple. And the husband was a psychiatrist and the wife is a psychotherapist. And they started collecting their data, and they had a pretty good sample size of about 1,000. And I think since then we have more and more data. And they were trying to say, well, what's the benefit of this? And we'll talk more about that. But when you look at what most of the literature will say is they'll say NAD's been around since the 60s. I always tell people, in my education background, I didn't take a class in NAD. I had some fantastic mentors, and I learned from being out in the field about NAD and some of these different IV therapies. And it's in that experience that I learned that NAD has been around for probably much longer than since the 1960s. We just need to get looking outside of PubMed and look at other countries and look at what they are doing. So if you look at, for example, the literature out of Spain, Germany, and the Philippines, a lot of the ingredients within NAD have been studied extensively. And it goes back to insurance, and it goes back into understanding what you're giving somebody. And that's a multi-layered, probably, presentation in itself. But for those of you who have been in the field of NAD for some time, you're probably nodding your head saying, we actually have good data on the effectiveness of what is included in NAD. And these are some of the individuals that are studying NAD, and by no means is this an all-exclusive list. This is probably an ancient list, but it is here for you. And what I wanted to talk to you about and give you a little hint, look at where they're doing their research and what they're doing with their research. Because in 2 slides I'm going to tell you, I'm going to ask you, what is NAD? And I could probably go around this room and we'll go back to grade school and people will put their heads down and fill out a little piece of paper and say, what is NAD? And I guarantee you that more than half of this room will answer that question in different ways. And that's one of the fundamental problems with that NAD has right now. So we have neurotransmitter restoration being studied, we have metabolic pathways being studied, and we have amino acids being studied. And I'm very much simplifying this. We have major academic institutions looking at the benefits, and we have private practices and looking at this, as well as we have specific disease states looking at the benefit. So it is going beyond the world of addiction, and I will talk to that in later slides. But over the years, I have heard NAD referred to many different things. So, has anybody heard of NTR before? What does NTR mean? Neurotransmitter restoration. To me, that is what NAD does. That is not what NAD is. There is a difference. Then you'll hear it's a natural assisted detox. And I think the word there is natural. Can anybody tell me what detox means? What do you think of when you hear detox? We do it here. That's where we need to start. It's okay, you don't have to speak up. I think it's being recorded. I'll talk to it. Can anybody tell me why it would be referred to as nutritional assisted detox? I'll give you the hint. called amino acids. That's the short answer. Can anybody tell me what an amino acid is?
Isn't that what the body already produces? So the detox process is trying to get you back to a homeostasis and a base zero to get your body to do what it naturally does anyway.
Beautiful. Yep. It's a depletion. But it is much more than just neurotransmitter restoration. Is it rapid? You'll hear it referred to as rapid. Yes. But how do they make that claim? What does that mean? Does anybody know? We'll talk about how quickly most of the NAD programs actually are. We'll talk about the scientific answer. We'll talk about what is referred to as coenzyme 1 and what that is. And then if we get down to it, we'll talk about this metabolic pathway when we talk about, anybody remember your biochemistry or your psychobio classes and axons and electron transfers. So go back to those days and get your phones out and Google a terminal button. It'll answer most of your questions. And so I think at the bottom, yes, there are many metabolic pathways. We're going to highlight just a couple of them. We'll talk about this electron transfer that you'll read a lot about from NAD over to NADH. We'll talk about, if we have any nurses in here, you are required to memorize what is called the Krebs cycle. If you have that background or you really want to understand the mechanism, this is not the presentation for you. Talk to me afterwards, and we'll go through Biochemistry 101. And we'll talk a little bit about how NAD is often referred to as this coenzyme 1. For those of us in biochemistry, niacin is E3. So we'll talk about the specifics about what is in NAD and those amino acids and vitamins and minerals. So can anybody tell me if you've had a conversation with me or you cheated and you went on our website and you picked up any of the literature, what does Sauber refer to NAD as?
Naturally assisted detox.
Naturally
Assisted detox.
Wrong, it's just like school.
Naturally detox. Naturally. I cheated, I worked for Sovereign.
Thank you. Natural assisted detox. So let's make it simple. This is the first of a couple slides that you will see. NAD is an IV treatment. How many of you have ever given blood before? Okay, it is not an intramuscular injection. It is an IV. It is not a pill. You will see that people will talk about it being an intramuscular injection. You will see that there are patches. You will see that there are different IV treatments. It is an IV drip treatment. Okay? What's the difference between all of those different routes of administration? Does anybody know? It's a basic difference, yes.
Isn't it how the nutrients are distributed in the body?
I've heard how fast. I would add the basic of how much, how fast something is accepted, and certainly absorption rates. Those are all the basics. And so when you hear about our program here, we're talking about an IV drip. So I always say it's similar to taking out blood, but instead of taking out blood, we actually are pushing the IV in to your system. You are sitting in a nice comfy chair, and we have an IV pull, and you are relaxing and hopefully detoxing. And we'll go through what the practical looks like a little bit later. But it's important that you understand that the protocol and most of the literature is based on an IV protocol. And it's important that your takeaway is NAD is about amino acids. And yes, we'll talk about the improvement with brain function. And yes, we will talk about the metabolic pathway with cellular energy. And yes, we will talk a little bit about withdrawal symptoms, when they are the most common, and that will be towards the end of the presentation. But there's a reason why that last slide is there. How many of you have actually read about NAD and done some research? How many of you, when you first read that research, drew the conclusion that NAD solved all your problems?
Great.
If you read a lot of the literature, it is really interesting because you will get the impression that NAD will fix every problem that you have. NAD is a tool. It is not replacing recovery. It does not replace each one of you as a professional. It is what I call a tool that's really about craving reduction so that we can then hand off the patient to you to do what you do best and work through the talk therapies. So let's talk a little bit about what does NAD do. In a later slide, we'll talk specifically to repairing the damaged cells. I think the most important bullet point up here, if you get nothing out of this presentation, is craving reduction. So at this point, if you want to leave, you should leave. If I have put you to sleep, you should go to sleep. NAD is about craving reduction. Can anybody tell me? This is where I start to get obnoxious. If I haven't been already. NAD is what? What?
Craving reduction.
NAD is made up of what?
Amino acids.
Awesome. Remember, my objective in giving this presentation is to walk out the door and you can tell the person sitting next to you, this is what NAD is. That you can start looking at the literature and approach the literature with a critical mind. Are you going to have clarity of mind? Yes, we'll talk about the clarity of mind. We'll talk about crossing the blood-brain barrier, what I often call cognitive fog. How many of you have had or taken a decongestant? Nobody's ever had a cold before in this room? How does your mind work when you have a cold?
It doesn't.
It doesn't, right? You kind of feel like, oh my gosh, I'm walking around with this cloud over my head. In the neuro world, we call that cognitive fog. There is some clarity of mind, often referred to with NAD in some of the treatments. I added this, reduced physiological and psychological symptoms. We, in my opinion, do not speak enough to the physiological benefit of NAD. In the world of addiction, everybody in this room probably knows, does addiction only impact the brain?
No.
We certainly don't support that notion here at Sovereign. So, but when you go on and you do your lit reviews and you look at NAD, you will hear a lot talked about the psychological benefits. But in this presentation, I'll only hint at some of the physiological benefits. This is where that psychoneuroimmunology, that connection between the mind and the body, the immune system, your endocrine system, your digestive system. There's a lot of good data in that world. There's a lot of good data in the functional medicine world. There's a lot of good data in the immunology world. For those of you that are saying, you know, I'm not an addict, and what would be the benefit to me? So those of you that want to look at that data, it's out there. It's not the purpose of this presentation, but hopefully we can talk a little bit more about that towards the end. We will talk about the benefit to the immune system. And what did I say probably is the most important thing about NAD? What does it do?
Craving reduction.
Okay, you're only going to hear that now 3 times so far, and probably 10 times. And so this withdrawal symptoms, you're going to see some great results published about NAD, and most of that is based on programs that have been 10 days. Here at Sovereign, we have a 3-day, a 5-day, a 10-day, 15-day program. But we'll see with craving reduction at 70 to 80% based on a 10-day duration of a program. I won't go through that, and you'll hear me say that again in later slides. How many of you feel tired at times?
We're a bit going up.
How many of you are bold enough to say that you've ever been anxious? Okay, I think I got about 80% of you. Here's where I get all of you. How many of you know a patient in the world of addiction that doesn't have either anxiety or depression incorporated into their addiction? Yes, I'll say it another way. I think every single patient in addiction has anxiety or depression. Is there anybody that wants to argue with me? I love arguing. I don't really love arguing. So you're going to hear a lot about the benefit with anxiety and depression. And going back to how that goes back to the physiological side, there's a lot of good literature looking at NAD and the role that depression and anxiety have with the immune system and the gut and the endocrine system. And from a neurotransmitter, this is probably where I'd say 70, 80, Brian, would you agree? Most of the literature is really talking about neurotransmitter restoration. So, at a master's level, most of you have taken your psychobio class. What are some of the neurotransmitters that we always talk about when we're talking about depression? We're talking about anxiety.
Dopamine.
Dopamine, I heard it.
Serotonin.
Serotonin, I heard it.
GABA.
Okay.
GABA.
Sometimes we'll hear about GABA. So we'll talk about the role of these neurotransmitters, more specifically dopamine and serotonin. I don't go through each specific neurotransmitter in the mechanism, but we'll talk about the role there. So maybe I have hinted at who can benefit from NAD. And maybe you can look around the room and look at the person sitting next to you in a different light now. I think, and at this point, we'll just have somebody come in and give everybody 3 IVs. And then you will have your brain restoration. But really, here at Sovereign, we look at NAD as a benefit to most of our patients. And here are some takeaway messages. We're going to get more specific in future slides about the neurotransmitter restoration. We're going to talk about how it's drug-free. We're going to certainly talk about this is naturally occurring amino acids, as the young lady in the front spoke to. And really, when we're talking about our patients, we have just identified some of us have anxious patients. Some of us have depressed patients. Those of you at Sovereign know we have special programs for depressed patients. We have EMDR, right? We have TMS. We have other programs. Does this replace those programs?
No.
No, not at all. It is just a tool. How many of us raised our hand when we talked about fatigue? And I think 90% of the room. How many of us know when you're dealing with your patient, how many of them have a stressor? I have never met a patient, I don't know how many years I've been practicing, I think it's around 15 years. How many, I don't think I've ever met a patient that didn't have a reason to use. Has anybody in this room? No, we may not agree with their reason. And we may not necessarily think that they handled it the best way, but they all had a reason. And so what we're really trying to do with NAD is give them that motivation and that sense of well-being. This is a tool. Let's get them started so that we can hand them off to you. You're the professional. You're going to work through the reason why they turn to that addiction in the first place. And I think that's really, really clear. It needs to be really, really clear. So we're trying to work with the physiological. I call it kind of a tease of the psychological. If I can get you motivated, go back to Prochaska's stages of change. Right? So you feel different. I often say that's one of the benefits of NAD. If you feel different, do you have to listen to somebody with a bunch of fancy degrees? Nope. That's the beauty of NAD. And we'll talk about that. We'll certainly talk about how we hand patients off to some of our evidence-based practices with our DBT and CBT. Other places you'll hear it talked about as with solution-focused and more short-term therapies. So, I'm going to put it together for you, and unfortunately this is where most of my obnoxious repetition ends. This is the takeaway message that I think everybody in this room should know, and you now have an invite to leave again. What is NAD? It's a medically supervised, nutritionally assisted detox. Yes, we do have MDs involved, and we'll talk about that. Why do I get it? To reduce cravings. The question that everybody asks, will I get sick? We'll talk about that. And I often say, if this was the first time that I have done this, then, and I poke you more than once, you are going to be irritated that I poked you more than once, but that's about it. And you're going to be irritated with me or whomever is giving you the IV, right? Is that anything different than when you go get blood and somebody pokes you and they can't find their vein? And then we'll talk a little bit about route of administration. And the data is pretty strong in the effectiveness with craving reduction. Based on a 10-day program, depending on which data you look at, the research states 80 to 90% reduction in craving. So, can anybody in this room tell me something else in the world of addiction that can match those numbers with craving reduction alone? I don't think it exists.
How does it compare to Suboxone or methadone or opiate maintenance? It's different.
It's different. I think beyond the obvious natural versus not so much, I think we'll talk a little bit about
Neurotransmitter.
yeah, let's save it to the end, and then we'll talk a little bit more to that. Here what you see are amino acids, and I think I started this, and those of you that have heard me talk about the presentation in the past, what are amino acids? Think of them as proteins, okay? This is a sequence of amino acids. I'm going to kind of skim over this because of the sake of time. I'd rather have dialogue and answer specific questions. But we have many, many types of amino acids, and I'm going to make this really simple. If you really care about the mechanism, contact me. I have entire presentations that only go through the mechanism. But for the sake of time, I'm going to speed through this. But think of amino acids as in a form of proteins, which is a sequence of amino acids. And highlight, you can't see this, it's more than neurotransmitter restoration. Okay. I've said it a couple times. We'll look at the connection with the endocrine system, digestive system, muscular system, immune system. And that's why, if we go back to the third slide where it said there's hundreds of metabolic pathways, there really are a lot of metabolic pathways. So this is our fancy Welcome to Med School 101. I want you to draw this picture and I want you to memorize it, and you've got 5 minutes to do it. When we talk about metabolism, this is what NAD looks like. you're going to hear a lot about the giving off of an electron. If you really want to learn more, we'll talk more about the Krebs cycle. I'm going to spare you the time with this slide for the sake of time. But what I do want to focus on is this bullet point here. Because I think the next slide talks about the real benefit of what happens for an addict and how NAD comes in. And so what we're talking about here is what happens in the cellular process when the drug itself removes that chemical group from that protein, and how that translates in that enzyme and how NAD targets that area. And so we'll talk about the target being that cellular structure that's involved in the pathology of addiction. So here, if we can see, go back to your good old days. This is your axon. Remember, NAD to NADH is excitatory. It's metabolic, so we're talking about movement along here. These little orange guys are our neurotransmitter. In this case, you'd see an excitatory release of dopamine. Okay? So this is your terminal button. This is your button. We're trying to get these excited dopamine to come over here. What happens in this case, we used cocaine. You can replace cocaine with your drug of choice. It comes over and it's blocked by this receptor. So in short, what happens is you have this excess stimulation of your neurotransmitter, and then it gets blocked and impaired. And what is the result? What's the result of not having enough dopamine? What's the result of not having enough serotonin?
Anxiety.
And we go through here, mood instability, irritability, because it's blocked, it's coming back, and the intensity of that dopamine receptor has essentially been weakened. For those of you that really want to get into this mechanism greater, for the sake of time, I'm going to speed past this. So when we talk about target, what we're really talking about, where is NAD helping? It's helping right here at the receptor. When we talk about mechanism, we talk about stress, and we'll talk about something called the Hpa Axis. And for the sake of time, I think what I'm going to do is I am going to skim over this. But what this talks about is the Hpa Axis. How many in this room know what I mean when I say that? How many in this room know about an autonomic nervous response versus a sympathetic nervous response? Fight or flight. Surprise, there's a tiger outside the door. What do you guys do? I came to the wrong presentation today, right? Joe's a little bit crazy. Some of you are saying a lot crazy, right? What happens to your immune system? What happens to your gut? There's a tiger outside the damn door. So, what we're talking about is the hypothalamus. So I always say, if I decide to take Tori's head here and drill directly through it, that's controlling, right smack in the middle, that's controlling emotional regulation, right? Maybe you're stressed, maybe you turn things off, maybe you get excited, you love tigers and you want to go jump on the tiger's back. I do not know. But your adrenals control your stress hormones. Your frontal lobe there is sitting there going, how am I going to respond to that tiger outside the door? And then we talk a little bit about this metabolic pathway. How long does that metabolic pathway last? So if I did this every day for the next month, and the tiger turns out to be the nicest tiger, and some of you are sitting here at the end of the month going, wow, Joe, I was scared at first, but tiger's the nicest tiger in the world, and comes in and you don't have the same stress response, right? So we'll talk a little bit about, if we have some time, talking about how that plays a role in the immune response. as well as how NAD plays a role in that. But it's a real important mechanism for those of you that want to go back and understand the mind-body connection. And that's why this slide is in here. All of your PubMed searches and what have you are going to be Hpa Axis and NAD. This is also really important when it comes to, this is a multidisciplinary approach. So you're dealing with nurses who are administering the NAD, you're dealing with psychologists and psychotherapists, and addiction specialists and psychiatrists. And so we need to know the language to unify each of us around this program. Okay, I'm going to spare you, I talked a little bit about this, I'm going to spare you the slide. We can come back to it at the end. Please read the slides if you haven't caught on. I don't read them to you. I think the most important thing that we're talking about here is craving reduction. And so when you stop using a drug, then everybody knows that your body and your mind often is going to have cravings, right? So you can start reading, you'll see a lot of literature talk about post-acute withdrawal syndrome. And that's a presentation in itself. And I think we talked to the neurobiology and pathophysiology here. And for the sake of time, is there anything on that slide that anybody has any questions about that I didn't say? You can raise your hand and we'll come back to it at the end if you're old enough to say. All right. Anybody, let's just talk about some of the symptoms that your patients probably have, and I think this is pretty clear. Any of your addiction patients ever have disinterest or unrest, or only about 98, maybe 99%? Any of them irritable? Only about every single one. Any of them have a difficulty with feeling the pleasure? I think that's a huge one and a huge reason why it's really important to connect the mind and body and the integrative side of that. Ultimately, that's the goal. Certainly, I've only mentioned drug craving reduction now 7 times. I think by the end of the presentation, I may make more time. So those of you counting. Here's where you'll see some of the symptom reduction and some of the diagnosis. You'll see in the world of schizophrenia, anxiety, depression, we talked about that. A lot of your mood disorders, if you go back to the research that was listed, you'll see specifics with like Parkinson's and neurotransmitter restoration and some of the nervous system diagnosis. You will see, we talked about fatigue in the fibromyalgia world. We'll talk about immune relation between fibro and some of the autoimmune diseases. Chronic pain, it's very specific. Talking about eating disorders, let's talk about endocrine system versus gut, and what's the whole focus of an eating disorder, that connection between the mind and the body, the perception of what is okay versus what is not okay, and really understanding and trusting your body, that it's actually okay to have that relationship with food, right? So we'll talk about the benefits of that, and certainly from an addiction standpoint, most of the literature will tell you that there isn't a drug of choice that NAD hasn't shown a benefit to. So, take-home message, we know that our neurotransmitters need the restoration. We know that we're talking about craving reduction. We know that our patients feel like they have a clarity of mind. We know that it has benefits. So I think the last probably 2 or 3 minutes that I want to talk to is what does it look like? Patient comes in, we have nurse, they fill out general intake like everything else. They inform consent, all the records are kept separate than your personal records. They have HIPAA, they have consents that says this is how we're going to do this. We have a 3-day, 5-day, a 10-day, and a 15-day program. And then we have boosters. And those boosters are 30-day follow-ups. and our physicians are scheduling and saying it is okay for this person to go into our NAD program. So our MD, our physician assistant, is prescribing the NAD. Those of you within Starboard, I will go through the protocol in a presentation very soon. And we'll talk about what's actually in it and the dose and the route of delivery. I'm going to spare you the time today. This doesn't take away their current medications that they're on. It's really important. That's why that MD needs to be involved. So we are still administering all their medications. And of course, our staff need to know how to administer an IV. They are going to be monitoring. Here's some of the things that ever so often come up during the IV treatment. Certainly, has anybody had IV of any kind of amino acids or vitamins in this room? Yeah. So this is almost a kind of take-home message for any IV, NAD or not. The real big thing right now that's really popular is something called Myers cocktail, and another one that you hear about is glutathione. These are natural, and if you want to talk more about these, but the symptoms are pretty similar. Some people get some sinus pressure. You do feel the drip actually going in. Some people get some chest pressure. A lot of times the chest pressure is because whoever is administering it doesn't have a clue what they're doing. Can I say that boldly? And I say that because you can change the rate of administration. And that chest pressure is because they did it. And it's kind of like this. If I take this young lady's arm and I'm administering the IV, and the IV infiltrates or it falls out of the vein, normally she feels it. But what happens to our, thank you for your hand. What happens to that addicted patient is a lot of their somatization and their sensing, they often may not speak up. So it's really important that this is very monitored. And of course the gut, and we'll talk a little bit about when a patient actually may have some GI. But it's really simple to adjust, and I'd say the vast majority of our patients, we've done this for a long time. Remember, this is not brand new science. You can adjust the rate and we should not have that problem. If somebody comes in and they have the HTN is hypertension or diabetes that's unmanaged, we really need to manage and make sure that that's stable before the patient comes in. And that's why you have the physician involved. So it's drug-free, it's evidence-based, minimizing the pause, eliminating cravings. I always focus on anxiety and depression because everybody in this room agreed that we all have patients and ourselves at some point know about anxiety and depression. And the most important thing is it motivates them. How many of you think that your patient could benefit from feeling different and getting motivated, and how much that would help you? What is the number one problem that we have with our patients when they're
Cravings.
Cravings? And let's just get them started, right?
Motivation.
Yeah.
What a great tool. Buys them some time. I'm going to spare you the nursing orientation. So I think I talked a little bit about this. We explain our protocol. We're doing our drug testing. We're managing our meds. And it's at one of our homes where the patient is in a relaxed environment. And I'll certainly talk more about that. So it's, this is our take-home message, and that's the last slide. So, and now I'm at my number 10. I think you have now heard me say each of these things at least 10 times. So hopefully my objective was clear. I wanted you to walk out the room and say, what is NAD, and be able to turn to the person next to you. Hopefully you got that. If you have specific questions about the program, I think at this point I will turn the presentation off, and I'll certainly yield as many questions as I have time for. It looks like we have at least 10 minutes. I know some of you have to go on.
So why does insurance not cover it?
Good question. And this is where we may want to, and the gentleman who had that question just left. And I don't know if we want to open that door to tell somebody that as I answer this, don't think this should be put on the video.
Thank you. You just go on the video and discuss and you register.
I'm not sure, but hopefully talk a little bit about insurance for a while. There are places where you can get NAD actually reimbursed through insurance. And at one point, Sovereign was doing that. We are not doing that right now. Right now, NAD is a cash-based program for us. If you go to the private practice, prior to Sovereign, I was opening functional lifestyle medicine practices across the nation. And I always joke and I go, there are parts of Beverly Hills where in a 2-mile route, we probably had 5 practices from 8 o'clock in the morning until 9 or 10 p.m. They were full, and basically all we would have a setup that was all NAD all day long. And the average patient per day was paying $5,000, $6,000, $7,000 cash. NAD is not cheap to purchase. So some people say that's a lot of money. That's a small portion of the population that can afford that. You can do that in a place like Beverly Hills. There's a lot of business rules why that is. We are charging $1,500 a day. And we think that that's a very fair price. We're not the cheapest. We are down towards the low end. We are really looking at NAD as a tool that is an ancillary to our bread and butter, which is you, and the services that you offer. And so we wanted to make it affordable. And I think that's really important that everybody understands. Right now, it's not going through insurance, and some of that has to do with the different types of and how medical is involved. So when you look at the other programs, you have to look at the scope of the physician. You have to look at what the physician is looking at from a medical standpoint, and that's the short answer into how it can be reimbursed. And it's not something that at Sovereign we have said that we are not opposed to. It's just something that at this given time we haven't incorporated. Does that make sense? Other questions?
Dr. Joseph, how long have you been with Sovereign Health?
Now you're asking the hard questions. Those of you that know me know that I don't know what day it is. I want to say around 7 months. Does that sound right?
Sure.
Yeah.
Yeah.
I think I was a little behind Dr. Mealy.
The second part of that question was, we've had this since day one. It's been very successful with Sovereign Health. I've had 12 patients complete this, where they actually took us clinicians and other people in to see it, watch it perform. It's been fantastic. And then it just kind of went down and it wasn't talked about again. I think if we can get that back up again, more people would be like, yes. Because this is what they hear, Dr. Joseph, well, you gotta do this, and then you go to the NAD house, executive house, you can't afford that, that's why for private pay, scares them.
Well, I think you have just nailed on the head the internal concern that Sovereign has had. If you look at the patient's experience, we have fantastic reviews. Even outside of and testimonials, we have, most of our concern has come from an operations standpoint. And so Brian and myself and kind of the team have been trying to do exactly that. When somebody calls on the phone and wants to know about NAD, they want to know about the handoff after they do NAD. They want to know that it doesn't solve all your problems, okay? They also want to know about not only cost, but having transparency in that communication. So we are just now launching our marketing efforts, just now launching, and I think, Brian, you'll have to correct me, I think I told you, I never know what day it is, but we are pretty new with our reintroduction of that. Meaning, it's been, I think I gave the initial presentation on that about 6 weeks ago. So we are just now revamping. I told Dr. Sharma, our marketing efforts are just starting this week.
That's good, because I just had a client from IOP going for an immune system. And she's already been detoxed, ready for this, 50 days. And she says, Miss Christina, I went in there for this. I said, well, why? You know, if you're feeling already. And she told me about it, but her skin, her hair to feel good again, reduce immune system to get ready to leave. And I asked her how many hours, because it was always 8 to 10 hours. It was here. And
so let me tell you a little bit about the practical side of it.
Okay.
On paper, it's always 8 to 10 hours.
Okay.
And that doesn't mean that, some people, it changes. It can go as low as 5 hours. And we're a little bit flexible with that. That's what a patient can ultimately tolerate. If you have patients that are interested, I'm happy to speak with any patient that you have. I'm happy to connect them with anybody on our team. If it be, we have a great team and pretty bright people that know if I'm not available, how to speak to a mom versus the client versus the cost stand of it. And we've really tried to work on that connection. So if you have a patient, what I don't want is I don't want you sitting there saying, I don't know who to go to. Or if you've gone to 2 or 3 other people and you go, I'm lost because I'm not getting any answers, email me. I get so many emails. If you don't email me, then call me. Is there anybody in this room who has tried to call me that I have not gotten back to you in 24 hours? I'm a little OCD. I will get back to you. But I don't want any patient to not have that opportunity. Yes?
How much does it cost the company to buy one IV bag?
Good question. Well, I can tell you this. It is, if you look at it from a business standpoint, I would not look at it from an IV bag. I would look at it from what makes up NAD. I would look at the IV bag. I would look at the variable cost in the ingredients. And then I would look at the size. Because if I tell you that I have a 5 ml vial versus a 30 ml vial, then like anything else in the marketing world, that 30 ml saves me money, right? But here's what is the hard part in figuring out cost. How long can I keep it on the shelf? Right?
Right.
So, and I can't keep it on the shelf. And so, can't keep it on the shelf long enough. So if you want, I'll give you some rough numbers, but I can tell you that those are ways to control your cost, but markup is actually really low here at Sovereign. That's why I use the example of Beverly Hills. markup is hundreds of percent in Beverly Hills. But it's a different, those of you with MBAs in this world know the whole world of marketing. That's a whole different conversation. That's a whole different. But I would be happy to say, and I'm pretty happy to say that Sovereign is not looking at NAD as an aggressive money maker from a standpoint of we want to treat patients, and we think this is a tool that's really going to help our patients.
Is there a better rate of recidivism if they stay longer? Because you talked about all those different time frames we all.
So we had it's kind of like, and going back to the cost, it's kind of like this. There are ways to save money in any business. We look at efficiency, shelf life. We look at a patch versus a pill, an IM versus an IV. So we'll talk about all of those differences if you want to join the NAD team, and I'm happy to. I don't think that this is the place to talk about that, but you got to remember, you got to know what's going into each IV and the variable cost. That's going to change everything.
If Hpa is post-acute withdrawal symptoms 18 months, let's say it's 18 months.
Oh, I'm sorry, I forgot the last question. Sorry, you just reminded me.
Does that reduce the amount of time that Hpa is for that patient if they go through NAD because they've withdrawn that much more in a constant period of time?
I don't have an amount of time that you see that reduction off the top of my head. I think the literature does exist. It's more about reviewing the intensity alongside the duration.
The intensity, yeah, which is huge.
So it's not like it cures it or says it goes away, but, and going back to the 3-day, 5-day, 10-day, 15-day. We added the 3-day basically because when we looked internally and I looked at the types of patients that were inquiring, a lot of patients go, what is NAD? Just like the vast majority of this room did. And I wanted to give the patient an experience. Most of the data is not on a 3-day program. The 3-day program is about, look, you don't have to listen to me. You don't have to listen to person X, Y, and Z with fancy degrees. Try it. We got plenty of data. I'll give you all the data. I'm happy to speak with you. I'm happy to connect you with anybody on the team. But what you do see is you do see patients, depending of course on what they're coming in with, but on average, day 3, 4, 5, they start feeling better. Then it speaks for themselves. It speaks for itself. So then you don't, I always say, I got a bunch of fancy degrees. It means nothing. If the patient sits there and the patient tells you, I actually feel I'm getting that clarity in mind. Did it solve their depression? Did it solve their addiction? No. But that's, remember, the point here is craving reduction so that I can hand it off and say, you didn't get that eating disorder in a week. You didn't get that eating disorder in 2 weeks, did you? Nope. You didn't get that addiction in a week. So I like to think of it as a tool. And the 5-day, I think, is where the patient starts to, you look at, I kind of look at research like this. Let's line up 10 different docs, and what do they all agree on? Well, what they will all agree on is at about the 5-day, the 4-day, 5-day mark, most of the patients are starting to feel better, regardless of what their drug of choice was. So, and that's really where that is. And we're happy if a patient comes in at 3 and wants to extend to 10, awesome, great, we'd love to have you. And we do have every intention of rolling this program out into each of our locations.
let's say if a patient lives, like resides close by and wants to come and do this NAD program as an outpatient, can you do that?
Yep, we also changed that protocol. So, a patient is welcome to stay in one of our homes, a patient is welcome to go back to their home. Hopefully everybody in this, we are also willing to get a patient a hotel. I think everybody in this room knows that there are pros and cons to that. We're dealing with addicts. So I think as I'm looking around the room, I saw some eyes get bigger. We're well aware of that. We've had that dialogue. We haven't had a single patient, and we don't offer it. We don't sit there and say, we'll put you in a hotel. No, we say if you need a highly structured program, if you need, you know, right? Because that's what everybody in this room agrees with. You wouldn't be in this world of addiction if you didn't agree with that. Again, it comes back to, there's some commonalities in the world of addiction. Structure is one of the big ones. Other question?
How many hours a day for the typical?
In the protocol, and I'm going to go through the protocol, I hope to send an email out internally for those that want to go through that. It's more of a training. It gets into the specifics. The protocol will state 6 to 8 hours.
And is it consecutive days? So if I sign up a client for 10 days, it's 10 consecutive days, it's that many hours a day?
Currently, we are not admitting on the weekend, but if I'm lucky, that will be changing any day now. Other questions? And I'm sorry, just so some may have to leave, and we are over, so I certainly want to, I did not know that we were over by 10 minutes. I want to make sure everybody has my last name. It's Raphael. If you have patients, if you have other questions, you have specific questions, I'm happy to be available. First name is Joe. I think online it's under Joseph. If I said something that was not clear or that you do not agree with, I'm happy to open dialogue about that. I am well aware that I did not answer every question that there is regarding NAD and how it fits into some of the other programs, but I certainly want to respect your time. So if you do need to leave, I will make myself available